Welcome to the deep dive. We are jumping straight into the material today because, quite frankly, your time is extremely valuable.
Absolutely.
This is a high-yield revision deep dive hosted by two plastic surgeons, and it is specifically tailored for you, the resident preparing for board exams like the FRCS in plastic surgery.
Spot on.
Today's entire focus is the clinical pathology and management of osteomyelitis. And real quick, if you learned something valuable today, hit the follow button and rate the show. Also, definitely made a premium subscription to listen to the Journal Club and Clinical Cases deep dives.
Highly recommend those.
Okay, let's just get right into it. When we talk about osteomyelitis, we're essentially looking at an inflammation of the bone driven by an infecting organism. But for the FRCS, you really need to nail down the precise timelines used to classify its duration.
Right, the time limits.
Yeah, we typically break this down into acute, subacute, and chronic phases.
And while those time limits can feel, well, a bit arbitrary in actual clinical practice, they are the absolute standard benchmarks you are going to be tested on. Acute osteomyelitis is rigidly defined as an infection lasting less than 2 weeks. Subacute falls into that sort of middle ground, lasting anywhere between 2 weeks and 1 month. And chronic osteomyelitis is defined as any bone infection persisting for more than 1 month.
More than 1 month, right?
Yeah. It is critical to memorize those cutoffs because the pathology and therefore your management strategy changes drastically depending on which timeline your patient falls into.
I mean, the timeline is really just the first piece of the puzzle. The second piece is understanding how the infection actually starts.
Right, the mechanism.
The primary mechanisms of infection generally fall into two broad camps: exogenous and hematogenous. And as reconstructive surgeons, we are very familiar with the exogenous route.
Very familiar.
This means the infection comes from outside the bone. You'll see this constantly with open fractures or, through direct contamination during an orthopedic surgery, or even from a local soft tissue infection like a severe diabetic foot ulcer that just simply spreads deep into the underlying cortex.
Precisely. And the counterpart to that is the hematogenous route, which just means the bacteria arrived at the bone via the bloodstream during a systemic bacteremia.
Right.
But regardless of whether the bacteria marched in from a dirty open wound or floated in through the blood supply, the host's biological response will typically fall into one of two categories.
Okay.
The response is either pyogenic, meaning it produces a significant amount of pus, or it's non-pyogenic. For the purposes of the acute pathology we see most often, we're usually dealing with a pyogenic response.
So let's put this into a clinical context for the listener. If we focus entirely on acute osteomyelitis first, we need to know exactly who typically gets this disease.
Demographics are key here.
Because the patient demographic is incredibly specific and highly testable. Acute osteomyelitis presents with a classic bimodal age distribution, doesn't it?
It absolutely does, and this is a favorite topic for examiners. The first peak of this bimodal distribution occurs in very young children, specifically those under the age of 2.
Under 2.
And the second peak happens a bit later, typically in kids between 8 and 12 years old. In these pediatric patients, the hematogenous infection almost always targets the metaphyses of rapidly growing long bones.
Which is fascinating, anatomically speaking.
It is, and the reason this is so crucial for your exams is that you need to recognize the physiological shift that happens as we age. Acute hematogenous osteomyelitis is actually extremely uncommon in immunocompetent individuals once their growth plates have completely closed.
That's a huge point.
Yeah. If you see a healthy adult with an acute bone infection, you should be looking hard for an exogenous source, not a hematogenous one.
That is a fantastic clinical pearl. Keep that in mind, guys.
Right.
Now, I want to dive into the actual pathology of the acute form because it's essentially a rigid pressure cooker scenario.
It really is.
It's wild to think about how a microscopic bacterial seeding can literally threaten an entire limb simply because of the physical constraints of human bone. Let's walk the listener through that exact 4-step cascade.
Let's do it.
It starts, as we mentioned, with that hematogenous bacterial seeding into the bone marrow, which immediately triggers a localized inflammatory reaction.
Right. That is step 1. The bacteria arrive, and the immune system immediately mounts an inflammatory response. Now, step 2, this intense localized inflammation in a highly confined space quickly causes local ischemic necrosis of a surrounding bone marrow.
It just chokes it out.
Exactly. As the tissue dies and the pyogenic response ramps up, a localized abscess forms.
And step 3 is where the anatomy of the bone itself becomes the enemy. I mean, bone is essentially a rigid box.
Right, it can't stretch.
It cannot expand to accommodate swelling like soft tissue can.
Mm.
So as that newly formed abscess grows, it drastically increases the intramedullary pressure within that rigid cavity.
And pressure is the real danger.
This rising pressure physically compresses the delicate local blood supply, leading to severe cortical ischemia. You're effectively choking off the bone's own blood vessels from the inside out.
Which perfectly sets up step 4. You now have a pocket of highly pressurized pus trapped inside a dying ischemic bone. That pus has to go somewhere. It follows the path of least resistance.
Naturally.
The pressurized pus literally forces its way out, escaping into the superior steel space through a newly created defect in the cortex. We call that opening, or that sinus tract, a cloaca.
A cloaca.
Yes. Once the pus breaches the cortex and lifts the periosteum, the acute pathological cascade is complete.
And obviously, if this whole 4-step pressure cooker is left untreated by medical professionals, it progresses. We can't just leave a superior steel abscess sitting there.
No, definitely not.
What exactly happens biologically when acute osteomyelitis is left alone and transitions into the chronic phase? There are 2 specific, highly testable terms here that every resident needs to know cold.
Yes, if left untreated, it inevitably progresses directly to chronic osteomyelitis. And those 2 terms you need to memorize are sequestrum and involucrum.
Sequestrum and involucrum.
A sequestrum is a distinct piece of dead necrotic bone that has completely separated from the surrounding healthy normal bone. It is basically an island of dead tissue floating in an infected space.
An island of dead bone. Got it.
An involucrum, on the other hand, is a thick sheath of new bone formation. Remember how we said the pus escapes through the cloaca and lifts the periosteum?
Yeah, step 4.
Well, that displaced periosteum tries to heal by laying down a new layer of bone right over the top of the infection. That new surrounding bony sheath is the involucrum.
So once that pus breaks through the cortex, and we know we're dealing with an acute infection, the immediate question on the ward is what exactly is growing in there?
The bugs.
The bugs, exactly. And the pathogens we target change entirely depending on the background of the patient sitting in front of you.
Yeah.
This is a classic pattern recognition scenario for the boards.
Absolutely classic.
Let's break down the common causative organisms based on patient demographics.
This is pure pattern recognition. If a board question describes a child, say, an 8-year-old presenting with a warm, painful, swollen leg, the most common organisms you must suspect are Staphylococcus aureus or Group B Streptococcus.
S. aureus or Group B strep. Okay.
However, if the clinical vignette describes a patient with a known history of intravenous drug abuse, your mind must immediately jump to Pseudomonas aeruginosa.
Pseudomonas for 5E drug users.
Exactly. For a patient who is significantly immunosuppressed, such as someone undergoing chemotherapy or with advanced HIV, you always have to keep fungal infections high on your differential diagnosis.
That makes sense.
Finally, the absolute classic board scenario. If the patient has sickle cell disease and presents with bone pain, Salmonella is the specific causative organism you will be tested on.
Salmonella and sickle cell. They love testing that. This actually brings us to one of the biggest clinical pitfalls you will encounter, both on the wards and in your exams. Let's talk about the timeline for investigations.
This is a big one.
Imagine you're on call at 2 in the morning. A 10-year-old comes into the emergency department with severe bone pain and a fever. The parents tell you this started about 3 days ago. You order some routine blood tests and a plain x-ray of the limb.
Standard protocol.
The x-ray comes back completely normal. The temptation for a junior doctor is to look at that clear x-ray, assume the bone is fine, and send the patient home. But that is a massive mistake, isn't it?
It is a catastrophic mistake, and examiners will test you on exactly this scenario because it happens all too often. You have to remember the strict timeline for imaging in acute osteomyelitis.
Right.
Bony changes, the actual visible cortical destruction or periosteal reaction, will not show up on a plain radiograph until at least 12 days into the infection.
12 days.
Yes. If you are waiting 12 days for an x-ray to prove your diagnosis, you have effectively allowed the acute infection to rampage through that bone cavity untreated.
So what should we be relying on instead of the plain x-ray in those early days? I mean, blood cultures are often the first step, but they're only positive in about 40% of cases.
30%, yeah.
They're helpful if they grow something, but a negative blood culture absolutely does not rule out osteomyelitis.
Exactly. The truly pivotal step in isolating the causative organism is Direct needle aspiration of the superiosteel space and the marrow cavity itself. You need that direct tissue or fluid sample.
What about early imaging?
In terms of early imaging, an MRI is highly sensitive and will show early inflammatory changes and marrow edema almost immediately.
Okay, MRI is great.
But if an MRI is unavailable, technetium 99-meter bone scans are also incredibly useful. They can turn positive very early, typically after just 24 to 48 hours of symptoms.
That is a crucial takeaway. Do not let a normal day 3 X-ray reassure you. So, knowing all that, once we have correctly identified and investigated acute osteomyelitis, what is our main avenue of treatment? Because, unlike the chronic form we're about to discuss, acute osteomyelitis is largely a medical disease initially.
That is the key distinction. The absolute mainstay of treatment for acute osteomyelitis is immediate, targeted intravenous antibiotics. You want to hit the infection hard and fast before massive necrosis occurs.
Hit it fast with IV antibiotics.
However, there is a very specific indication for surgical intervention in the acute phase. You operate specifically for the drainage of a sequestrum.
Ah, the dead bone island.
Right. If the imaging shows that an island of dead, isolated bone is already present, the surgeon must go in, create a cortical window to access the medullary canal, and perform a meticulous debridement of all that necrotic tissue.
Because antibiotics cannot penetrate dead bone.
They cannot.
Which perfectly transitions us into the piece that is chronic osteomyelitis. We mentioned earlier that acute progresses to chronic if it's poorly managed or left untreated.
It does.
The hallmark feature of chronic osteomyelitis changes the entire treatment paradigm. Why do our powerful systemic intravenous antibiotics, which work so well in the acute phase, suddenly fail us when the disease becomes chronic?
It all comes down to the physical anatomy of the chronic disease state. The defining hallmark of chronic osteomyelitis is infected dead bone sitting within a severely compromised soft tissue envelope.
Compromised envelope.
Picture the architecture of what has formed over those months. You have these deep infected foci hidden within the bone. Surrounding those foci is a wall of sclerotic, completely avascular bone.
No blood supply.
None. Then, covering that dense sclerotic shell, you have a thickened, abnormal periosteum, overlaid by heavily scarred muscle and fibrotic subcutaneous tissue.
It's essentially a biological fortress.
That is exactly what it is. This dense physical and vascular barrier makes systemic antibiotics relatively ineffective. The drug circulates in the bloodstream, but it simply cannot penetrate through the scar tissue and the avascular sclerotic bone to reach the infection in high enough concentrations to eradicate it.
And the soft tissue is usually a mess, too.
Oh, absolutely. Because this soft tissue envelope is so compromised and often breaks down to form open wounds, secondary superficial infections are incredibly common.
Right.
It's a well-documented clinical fact that samples taken from swabbing a superficial sinus tract on the ward will often grow completely different opportunistic bacteria than the actual causative organisms you would find deep inside the bone.
That is another massive clinical point. Swabbing a draining sinus tract on the ward is essentially useless for dictating a long-term 6-week course of IV antibiotics.
Completely useless.
You're just culturing the skin flora that crawled into the hole. You need a deep tissue biopsy.
Exactly.
Now, because eradicating this fortress is so incredibly difficult and requires both potent antibiotics paired with aggressive, often limb-altering surgery, we need a robust way to categorize these patients.
We do.
We can't just treat every chronic osteomyelitis patient the same. For this, we rely heavily on the Sierney and Mater staging system.
Yes, the Sierney-Mater system is arguably the most important classification you need to know for this topic. It's brilliant because it doesn't just look at the bone.
Right.
It accounts for both the physical anatomy of the disease and the physiological state of the host. You absolutely need both pieces of information to determine if your patient can even survive the massive reconstructive surgery required to cure them.
Let's break down the anatomical types first, because this dictates the physical surgery we will perform. There are 4 anatomical types.
4 types.
Type I is medullary. This is purely endosteal disease. The infection is sitting inside the intramedullary canal, but the structural integrity of the cortex is intact.
Type I is medullary.
Type 2 is superficial. Here, the outer cortical surface is infected, and this is almost always due to a soft tissue coverage defect directly over the bone, like a pretibial laceration that just never healed.
Very common in plastics.
Type 3 is localized. This means you have a full-thickness cortical sequestrum, but crucially, it can be surgically excised without causing mechanical instability of the bone. You can carve out the bad piece, and limb won't snap.
And then there's type 4.
Right, type 4 is diffuse. This involves a messy combination of features from types I, 2, and 3, but the defining characteristic is mechanical instability. The bone is either already unstable before you operate, or you know for a fact it will be mechanically unstable after you finish your aggressive debridement.
Exactly. The anatomical type tells the surgeon what needs to be cut out. But then we have to pair those 4 anatomical types with the physiological classes of the host.
The physiological classes, A, B, and C.
This tells us if the patient can tolerate the cutting. Class A is your normal host. They have normal immune function, normal vascular supply, and no major comorbidities.
The ideal surgical candidate.
Class B is a compromised host. This means there are significant local or systemic factors present that actively compromise their immunity or wound healing. We are talking about poorly controlled diabetes, heavy smoking, severe peripheral vascular disease, or systemic steroid use.
And then there's Class C, which completely changes your surgical game plan.
Indeed. Class C is termed prohibitive.
Prohibitive.
In a Class C patient, the chronic bone disease itself might actually be causing minimal daily disability, maybe just a painless draining sinus. But the morbidity anticipated from the massive multi-stage surgery required to truly cure the osteomyelitis is prohibitive.
The cure is worse than the disease.
The surgery might kill them or cost them their limb unnecessarily. For these Class C patients, there's a very poor prognosis for surgical cure simply because the definitive treatment is far too dangerous for their fragile physiology to undergo.
This highlights perfectly why examiners love the Suturing system. It forces the reconstructive surgeon to treat the patient's physiology, not just the X-ray.
Absolutely.
Okay, let's unpack the actual plastic surgery management of chronic osteomyelitis.
Yeah.
This is the core of what you need to know for your FRCS exam. What is the absolute gold standard for diagnosing the specific bugs in chronic osteomyelitis, and what's our overarching strategic approach to treatment?
Well, diagnosis always requires integrating clinical exams, laboratory data, and imaging. The absolute gold standard is a direct bone biopsy.
Direct bone biopsy.
You must take a physical piece of the infected bone and send it for both histological and microbiological analysis. Imaging plays a vital supporting role to map out the anatomy before you cut.
Like plain X-rays.
Plain X-rays will show you the extent of cortical destruction and periosteal reactions. You will often use sonograms to track exactly where the fistulas lead, alongside CT and MRI to precisely map out the dead bone and the surrounding soft tissue deficits.
And as for the overall strategy, your treatment choice is heavily dictated by that Suturing stage we just went through.
Yeah.
You and the patient have to sit down and make some hard choices.
Very hard choice.
Are we pursuing a simple treatment or a highly complex reconstruction? Are we aiming for a definitive curative treatment, or are we accepting a palliative approach for a Class C patient?
Right.
And most crucially, is this a limb-sparing scenario, or are we looking at limb ablation, meaning a major amputation?
Because the stakes are that high, this level of decision-making strictly requires a multidisciplinary team setting. You cannot do this in isolation.
The MDP is essential.
You need orthopedic surgeons to manage the bone stability, plastic surgeons to manage the soft tissue envelope, infectious diseases specialists to manage the complex antimicrobials, and medical microbiologists all sitting at the same table.
Everyone has to be on the same page.
Long-term antibiotics are absolutely utilized, but they are based strictly on the deep bone culture results from your biopsy. However, make no mistake about it, while antibiotics suppress the infection, adequate surgery provides the only chance of a complete permanent cure.
Let's talk about that curative surgery. To eradicate the infection, we have to dismantle that biological fortress we talked about earlier and create a viable, highly vascular environment.
We have to tear down the walls.
What are the actual surgical steps we take to make that happen, particularly regarding the soft tissue coverage that falls to us as plastic surgeons?
There are 2 main components to a curative surgical approach. The first component is the aggressive, radical debridement of all affected bone and soft tissues. You cannot be timid here.
Radical debridement.
You have to use a burr or a saw and cut back until you reach actively bleeding, healthy tissue. We call it the paprika sign. You want to see pinpoint bleeding from the remaining healthy bone.
Paprika sign. I love that visual.
If that massive resection results in mechanical bone instability, a type 5V scenario, it is typically treated by the orthopedic team with the application of a circular external fixator frame, like an Elizaroff frame.
Then comes the second component, which is where plastic surgery really steps in to save the day dead space management.
That's our territory.
Following that massive orthopedic clearance, you now have a huge physical void where the infected tissue used to be. Leaving a dead space simply invites a massive hematoma and a recurrent infection.
It's a recipe for disaster.
Managing this usually requires the importation of vascularized soft tissue. We need to physically fill the void and bring a robust, fresh blood supply to the area to help the systemic antibiotics reach the site.
Exactly.
Typically, in the modern era, this is achieved by performing a free tissue transfer, a free flap, usually a muscle flap like a latissimus dorsi or gracilis, plumbed directly into the local vessels.
The free flap brings the blood supply that the sclerotic bone was lacking, but a free flap is not always the chosen route. Sometimes, due to severe patient comorbidities, a lack of usable recipient vessels in a traumatized leg, or simply patient preference, a microvascular free flap isn't viable.
So if a flap transfer isn't used for whatever reason, what is the classic alternative strategy for managing that massive bony dead space? We need to be able to visualize this process because it requires an incredible amount of patience from both the surgeon and the patient.
The classic, time-tested alternative to flap transfer is the Papineau technique.
The Papineau technique.
This is a highly systematic, staged method of open bone grafting. Let's walk through the steps so you can picture it on the ward. Step 1 is the standard, aggressively radical debridement we just discussed.
Right to the paprika sign.
But following that clearance, instead of covering it with a flap, the wound is deliberately left wide open. It is managed with daily, meticulous, moist dressings. You continue these dressing changes for weeks, waiting until a bed of healthy red granulation tissue is present throughout the entire wound bed and over the exposed bone ends.
It's a waiting game.
It really is.
And once that wound bed is perfectly clean and actively granulating, you move to the next phase.
Correct. Once you have that healthy bed, the massive bony cavity is packed completely full with strips of autogenous cancellous bone graft, usually harvested from the patient's iliac crest.
Pack it full of cancellous bone.
The exposed wound and the newly packed bone graft are then covered with moist, antibiotic-impregnated gauze. I should also note for your exams that a modified technique using negative pressure wound therapy, a VIC dressing placed directly over the bone graft, has also been described, and it is widely used today to speed up the process.
A VAC dressing over the bone graft. And after you pack it and apply the dressing, you go right back to waiting.
More waiting.
You wait for the cancellous bone graft to become completely incorporated and overgrown with new granulation tissue creeping in from the edges and the base.
Exactly.
Once that entire bone graft is vascularized and covered in granulation tissue, the wound is definitively closed by applying a simple split-thickness skin graft over the top. It's a brilliant technique, but as you can see, it takes months of dedicated care.
It does. It requires absolute patient compliance and relentless wound care, which is why patient selection is so critical.
So what does this all mean for us as reconstructive surgeons? Treating chronic osteomyelitis requires an incredible amount of patience, precise multidisciplinary coordination, and a deep understanding of host physiology.
It tests every skill you have.
As we wrap up this revision session, I want to leave you with a final provocative thought to mull over as you continue to study this topic.
Right.
If we consider a patient categorized as physiological class C in the Suturing system, a patient where the morbidity of the massive debridement and free flap surgery itself is considered prohibitive, how do we as reconstructive surgeons fundamentally redefine success when a complete surgical cure is entirely off the table?
That is the big question.
Do we measure success by a reduction in pain? By preventing an amputation for just a few more years? By simply managing a draining sinus so they can wear normal clothes? That is the kind of higher-level clinical judgment and mature surgical philosophy the examiners are looking for in a consultant-level candidate.
It's a fantastic question to ponder, and one that separates the textbook reader from the true clinician.
Thank you for listening to the Deep Dive today. Remember to hit follow right now so you never miss a revision session. Rate the show if you found this high yield, and make sure you get that premium subscription to access our Journal Club and Clinical Cases Deep Dives. Leave comment or question below and let us know your thoughts on treating Class C patients. How do you manage them in your unit? Keep studying hard, trust your training, and we will catch you next time.